Welcome to another lecture of Psychology 101. This is your instructor, Dr. Shadi, and in today's lecture, we will discuss psychological disorders, which corresponds to chapter 15 of your textbook. So here we go. Consider the following. 1 in 5 adults, and that's 20%, 1 in 5 adults in Canada will be diagnosed with a psychological disorder at some point in their lives. And when I say psychological disorder, I mean a diagnosable psychological condition, as is diagnosed by something like the Diagnostic and Statistical Manual, and we will talk about what that is in a second. So 1 in 5 Canadians will be diagnosed. Overall, the collection of anxiety disorders make up one of the most prevalent of all diagnoses. So they affect about 18% of all adults in Canada in a lifetime. Okay, so if you span out, or you zoom out, if you will, and you look at the person's lifetime, 18% of people will develop some kind of an anxiety disorder, again, in keeping with diagnostic criteria in the Diagnostic and Statistical Manual. And about 11% of adults in Canada will develop a mood disorder, in particular, major depressive disorder, at some point in their lives as well. And you have to remember that there's a great deal of overlap, of course, between the people who develop mood disorders and anxiety disorders. So you can't just simply add the two together, because that would include a large area of overlap, about 70% overlap to be exact. And for that reason, we say 18% will be affected with anxiety and 11% will be affected with mood disorders. But these numbers, however you want to slice them, are staggering. Okay? They're staggering. And more recent estimates are telling us that the numbers are not getting any better, unfortunately. In fact, there's evidence to suggest that the numbers are actually getting worse. People are being diagnosed at a higher prevalence rates now more than ever. Okay, so it's really is a bit of a mental health epidemic, if you will. It's easy to sound the alarms on such a thing, and I see a lot of people, using slippery slope arguments and very dystopian views of mental health. However, the numbers are very, very staggering. There's a great number of people that will be affected by a psychological condition at some point in their life, and these psychological conditions are extremely debilitating. Okay, just to put that in context as well. But before we talk about diagnosable conditions, before we discuss what is abnormal, we of course have to first define what we mean by the term abnormal. What constitutes abnormal behavior? And in answering that question, of course, you are also answering the question related to how we define normal generally. Okay, because as soon as you demarcate what abnormal is, you now make a statement about what normal really is. Okay, so as you'll see, defining abnormality is a very difficult endeavor by the nature of the very elusiveness of what we mean by normal. Normal is not easy at all to define, and there's really no kind of blanket consensus across every single individual as to what they consider normal, and by extension, what people consider abnormal. So to give you a sense of how difficult of a task it is to demarcate normality from abnormality, I want you to consider the following scenarios. Your cousin is pregnant, and she's dieting, and she consumes about 800 calories per day. She's worried about getting too fat with her pregnancy, and really she's been engaged in this type of restrictive caloric intake since she was about 13 years old. Okay, so there's some precedent here in terms of this is her baseline behavior, if you will. Is this normal or abnormal? So think about that. Really consider it. Here's a second situation. A woman's husband of many, many years dies within the span of a year or so. And people have witnessed the widow, and she appears to be talking to herself in her backyard, for example. Her hygiene is starting to suffer. She doesn't wash herself very frequently. She lost a lot of weight. Is that normal or abnormal? Okay. So really do consider these two scenarios. And if you have considered them, it will give you a flavor as to how difficult of a task it is to define what abnormal really is, okay? Which is really what this particular lecture is about. And over the years, we've used or have recommended the use of the 4 Ds, if you will, in defining abnormality. And the 4 Ds are deviance, distress, dysfunction, and danger. And we will discuss each of these criteria in a second or so, and the strengths and the weaknesses of each of them. With that said, you have to understand that each one of these criteria, if used to define abnormality, has problems, has limitations within it. Okay. One that we will not discuss is that final criteria up there, which is the criteria of danger, and I'll tell you why. There's really no evidence at all that psychological disorders are associated with an increase in the prevalence of violence. Okay, so people with mental health conditions, generally speaking, by far are no more likely to commit acts of violence than anyone else. And in fact, the opposite is often true. People who get diagnosed with mental health conditions are often, unfortunately, the victims of a lot of violence in our society. Okay, so right away, that's a very shaky criteria to define abnormality with. One thing I will note, though, there are a couple of special cases that, according to the literature, may increase people's tendencies to be violent. And these are if people are under the influence of drugs such as alcohol, and another situation where somebody's suffering from a particular type of schizophrenia, which is this very debilitating disorder, which is defined by a break in reality, if you will. So people lose touch with reality. And in very rare circumstances, someone will have persecution or delusions of persecution, as we'd like to call them, in the context of their schizophrenia. And these delusions of persecution look like people thinking that people are out to get them. The government is out to get them. Everybody they talk to is conspiring against them, etc. And in situations such as these, there is some literature to suggest that violence also goes up. But by and far, the modal response here is people with mental health conditions are not violent. And therefore, we will not discuss danger as one of these criteria, or the weaknesses of danger as one of these criteria, because I don't want to give it any more legitimacy than already has. So let's discuss the first criteria, which is deviance. And deviance is basically the argument for defining abnormal behavior based on how statistically rare of a condition or symptom that is, or based on the fact that it may not sit or fit with societal norms at the time. Okay, and there are obviously a lot of advantages to using deviance as a criteria. The first of which is that we can perhaps, create an arbitrary cut point, statistically speaking, and say, if anyone is showing a certain symptom or behavior that is on the tail ends, meaning not a lot of people at all engage in such behaviors, maybe let's say 2 standard deviations away from the means. All right, if somebody's engaging in behaviors or has some sort of a personality that that is so polarized in that way, that it's 2 standard deviations away from what's average, then maybe we'll use that as a definition for abnormality. Okay, so there's almost a very intuitive appeal to it, right? We'll see it when we know what deviant behavior looks like, and therefore we can call it out when we see it. Well, that's all good and great. However, there are, of course, disadvantages with this. So in the example earlier, I gave you the cut point of 2 standard deviations away from the mean, right? So if somebody is engaging in behavior that is that rare, so that as to a very small segment of the population is actually engaging in that behavior, and if it's 2 standard deviations, if you've been following along with the lectures, 2 standard deviations away from the mean means about 95% of people are not engaging in that behavior. So only 5% of people are engaging in that behavior. But why did I pick that cutoff of 2 standard deviations? Why not 1 standard deviation? Why not 3 standard deviations? Okay, so right away we see an inherent problem with using this deviance or statistical rarity argument to define abnormality, which is where's the cut point in which we say, you know what, this is normal versus abnormal. Secondly, do you have to show just one statistically rare behavior, or do you have to show a number of deviations? Third, the argument from deviance, and even, embedded within that word are just a lot of emotionality. Just by calling something out as deviant or statistically rare or weird or strange or whatever it is, it carries a moral judgment. Right away we say, this is weird, and therefore in our heads, our brain fills in the gaps, if you will. This is so rare as to say that this is weird or immoral or dangerous or bad, which is of course not at all or should not be one of the criteria by which we define abnormality. Okay? And on top of all that, on top of all these inherent difficulties in using the statistical or deviance argument to define abnormality, is the idea that these behaviors do not occur in a vacuum, and in fact, culture really influences what we define as normal versus abnormal, and culture really defines what will be statistically rare versus not. So one behavior that might be statistically rare in one culture might not be very statistically rare in another culture. Okay, so that right away we see inherent problems in using deviance as the sole criteria by which we define abnormality. What about distress? And distress here means when people report that having subjective feelings of being overwhelmed or unhappy with the symptoms that they're experiencing. So that's what distress means. And of course it has a lot of advantages. We don't have to rely on any cut points, for example. We don't have to make a kind of a cold statistical argument. We can just ask people, and people will tell us whether they feel distressed or not, because of course this is a subjective experience. Well, there are of course problems with using this as a sole criteria for defining abnormality. First problem with this definition is that judgment as to whether something is distressing or not could depend on someone's values or the criteria by which they use to define what distress is. And in fact, literature is showing us that people in different cultures will report different tolerance levels for distressing mental health symptoms, meaning that several symptoms of depression say this is extremely distressing for me, this is subjectively extremely distressing, and someone in another culture could be experiencing the exact same number and severity of symptoms but tell you, what, I'm managing just fine. Okay, so it's right away, it really depends on the learning history and the genetics of the person that's disclosing the distress. And part of the problem as well is that not everybody with a psychological condition will report being distressed. Okay, and we see that very clearly in a set of criteria. They're called paraphilias, which is any abnormal, if you will, and I'm putting quotes on that word, abnormal, any abnormal fetishes or fantasies or any recurrent urges over something that society deems as inappropriate, for example. Okay, so these are a set of conditions in the Diagnostic and Statistical Manual, and especially for a couple of them, which is sexual sadism, which is a condition in the DSM. Sexual sadism looks like when people get sexual pleasure or have fantasies about humiliating or being violent with someone else. Okay, so that's what sexual sadism is. And people with that condition don't necessarily report that they're distressed. Many people also with personality disorders don't typically experience subjective distress. Okay, so that right away is a problem. At least it's an incomplete way to define what abnormal behavior is. And then finally, how much subjective distress is necessary, which is kind of related to the first criteria that we discussed, which is deviance. We still have to make a choice or a decision as to where the cutoff is, and we'll say, you know what, based on this cutoff, this person is reporting enough distress for them to be diagnosed with a condition. And let's talk about criteria number three, which is dysfunction. And dysfunction is basically the idea that, you know, it's not about distress, it's not about statistical rare or socially inappropriate behavior that the person is exhibiting. Instead, dysfunction talks about the person not being able to function or adjust well, or at least as well as they used to before experiencing the symptoms. Okay, so they may be struggling with function or adjustment at work or at home, etc. So this definition, like the ones before, or this criteria, like the ones before it, has an inherent advantage. Again, little inference needs to be made. We can just look at somebody's performance before they say they're going to, or they have been experiencing symptoms, and then after they say they've been experiencing symptoms. As an example of that, if somebody's reporting that they've been in a depressive episode for a number of months, perhaps we can, if they're a student, we can look at their GPA before they said they started experiencing the symptoms of depression. And let's say their GPA at that time was 3.5. And then we could look at their GPA after they said they started experiencing the symptoms of depression. And let's say we find that their GPA slipped to a 2.5. Okay? Then we can say, you know what? This is clearly indicating that whatever that person is experiencing is causing some kind of a dysfunction, at least scholastically, and at school. We could say, you know what, this is pretty solid criteria then. Well, like the ones before it, it also has a number of limitations, this specific criteria, or criterion, I should say. One of the first disadvantages is, again, we have to make a decision as to how much impairment is actually needed, how much dysfunction is actually needed. So in the example that I gave you earlier, it was a slip of one whole GPA point. Is that enough? Should it be 2 GPA points for us to call it an abnormal behavior or a diagnosable condition? Secondly, even though I gave you that very clear example of somebody's GPA slipping after experiencing symptoms of depression, it's not often that we have something that measurable that we can actually figure out baseline and then post symptoms how they're performing. Life doesn't work that way. A lot of things that we need to do well are not necessarily measurable, nor are they measured on a very regular basis. So that's very difficult. And secondly, and again, similar to the problem of distress, not everybody who who is impaired functionally will have a diagnosable condition, and the opposite is true. Not everybody who has a psychological diagnosable condition will be impaired at their job. Okay? So I hope I painted how difficult of a job it is for us to define abnormal behavior. And the difficulty lies in this particular problem, which is that none of these criteria that I just discussed is really enough to capture the entirety of what abnormal or psychological conditions look like. Okay, so there's not one descriptive feature that's present in all of these psychological conditions. Some of them look quite different, and I give you a few examples, right? So some people may experience this distress that we talked about. Some people may experience these functional impairments. However, others may not. And that sometimes is embedded or inherent right into the diagnosis. Okay. Second problem is, again, in each of these things that we discussed, statistical rareness of a behavior, levels of distress that the person is reporting, the impairment or dysfunction that the person is reporting. All of these things still require us to make a decision as to where the cutoff lies between what is normal and what is abnormal. How much is enough distress? Where do we draw the line of this person is really struggling and therefore they need to be diagnosed with a condition? Okay? Where do we draw that line? Again, very difficult. And one of the major issues, of course, with trying to define abnormal behavior is that these things happen not in a vacuum. They happen during a particular historical time and during a particular culture, which means that depending on which historical time you look at and which culture you're examining, how we define what is normal or abnormal will change. It must, because of course culture changes the norms and the criteria by which we define these things. Okay? And I'll give you a few examples of that. There are cultures and religions, for example, that really emphasize people's personal connection or personal relationship with a creator or godlike figure. So this is especially true in very religious cultures, or of course amongst very religious people. And many people in these cultures or who practice these religions might report having what is called conversations with God, if you will. Even this historical context, would the person then who is saying that they have regular conversations with God, would that behavior be abnormal or would it be normal? Further, societal zeitgeist and societal norms are continually changing over time. So there's these symptoms or these criteria are actually occurring in a particular historical point in time. Okay, and of course, our moods as a society, our norms shift enormously. And I'll give you an illustration of what that is. So soon enough, we will talk about the DSM, or the Diagnostic and Statistical Manual, and the history of the DSM, which spans many decades. But for a very long time, and in fact about 20 years, when the DSM was first developed, and the DSM again is the compendium or the book that gives criteria for many of these psychological conditions that we diagnose. So it gives very clear criteria about what is diagnosable versus not. So it gives you lists of symptoms and how many symptoms the person needs to be showing, and how severe the symptoms need to be, and how over what periods of time the symptoms need to cluster together, example, or the person needs to show these symptoms. Okay, so for a very long time, in fact 20 years, the DSM had homosexuality as a diagnosable condition in the Diagnostic and Statistical Manual. 20 years. Until in 1973, with the revision of the DSM-2, people decided, let's take it out, because the attitudes And the science was telling us that this is clearly not an issue at all. This is clearly not a psychological disorder. Okay, it's just normal extension of just the human sexual experience. So these symptoms and these diagnoses, they all occur in context, whether it be cultural context, whether it be religious context, whether it be a socio-historical context. And therefore, how we define normal versus abnormal needs to be aware of such socio-historical and cultural context. It has to. Given the elusiveness of the definition of abnormality, one thinker by the name of Thomas Szasz basically came out and said, mental illnesses, as defined by modern psychiatry, mental illnesses do not exist. Instead, what modern psychology defines as abnormal and modern psychiatry define as abnormal or diagnosable behavior is in fact just what Thomas has called problems of living, meaning that these people just happen to not fit in to their particular societal context. Instead, what Thomas Szasz argued is that psychiatry is actually a branch of the law, and psychiatry and clinical psychology and anything that relates to defining and diagnosing mental illnesses, all of these are fields or disciplines that are designed to control individuals whom we deem as behaving inappropriately in our current society. So given this elusiveness, it was all a myth. It's all not real, and in fact just a form of control that society puts onto people. So if you have a few minutes, I challenge you to stop the video right now and watch this embedded YouTube clip, which is basically Thomas Szasz discussing these ideas that I just talked with you about in a forum context, if you will. Before we dive any further into the discussion of psychological disorders, let's get a few important definitions out of the way. Okay? First of which is this idea of classification. And you'll probably know that scientists are very much obsessed with trying to organize and describe and relate to things that fit within a subject, a specific theme or a subject matter of a particular discipline. Okay, so that's the field of classification, or the concept of classification. There's the concept of validity, which we've discussed briefly before. And validity here is similar to the concept that we talked about before, and before we defined it as basically if a measure is actually measuring what it purports to measure. So if there is a measure that says that it measures depression symptoms, it's valid if it actually measures depression symptoms as it says it does. So validity in the context of psychological disorders as well as diagnostic systems is whether a classification scheme is actually measuring what it purports to measure. So if the DSM lays out criteria for social anxiety disorder, the concept of social anxiety disorder as defined by the DSM is valid if, in fact, this criteria that are laid out by the DSM capture something out there in the world that does look like anxiety. Okay, so that's validity. Utility is a little bit different than validity. And what utility is actually concerned with is how useful of a construct or a concept is this. Okay, so it's not enough really in a world that's constrained by resources to say that this thing is valid and accurate or reliable, that is. And instead, not only that, we have to also show that our diagnosis, our classification scheme, whatever it is, offers some clinical utility or some usefulness. It helps us do our job better. It helps people get better. And finally, there's diagnosis system, which is a rule-based classification system to help us organize and understand disorders. And a perfect example of this is the Diagnostic and Statistical Manual, which is a diagnostic system. And we'll talk in a second. We'll talk about the Diagnostic and Statistical Manual and their particular approach to diagnosing mental health conditions. Two final definitions before we talk about the DSM. The first of which is what we call the categorical approach to diagnosing mental health conditions, and the second of which is the dimensional approach to diagnosing mental health conditions. The categorical approach simply says that health and disorder are qualitatively different states of being. That is, someone who is healthy and someone who has a particular diagnosis, as defined by the Diagnostic and Statistical Manual, for example, they're not like each other at all. It's like comparing apples and oranges. Not only that, two different diagnoses, such as the diagnosis of major depression and the diagnosis of of social anxiety disorder, these things are also qualitatively different from each other. It's like apples and like oranges. Okay, so the basic idea behind categorical approaches is there is a clear difference in quality between health and disorder and between different diagnoses. Okay, so it's just like apples and oranges, different quality, different essence to them altogether. And then there's the dimensional approach, which says that it's not, the difference is not in quality, it's not in the essence of the thing, but the difference is rather in degree or frequency or severity. Okay, so the dimensional approach says that health and disorder exist on the same continuum, and disorder just happens to be on the far end of that continuum. And for that reason, you can have people that are mildly depressed, moderately depressed, severely depressed. So it's different degrees of the experience of depression on that same continuum. However, most people, for example, most people in society, and in fact everyone, will be somewhere along that continuum of depression or somewhere along the continuum of anxiety. Okay, so it's not so much that these things are different qualitatively from each other. It's not like apples and oranges. It's just different colors of apples or different stages of the apple's life, if you will. And of course, one of the most prominent examples of the categorical approach is the Diagnostic and Statistical Manual, which I have been referring to many times so far. And Diagnostic and Statistical Manual is basically a compendium of different categories of different disorders, and within the DSM are laid out very clear criteria as to what meets diagnostic criteria for particular disorders such as anxiety, major depressive disorder, schizophrenia, you name it. Okay? So this book houses the criteria by which we define what is diagnosable versus what is not. Okay? And the criteria, according to the DSM, the DSM lays it out very clearly. It says, for depression, for example, you have to show, it gives you a list of 9 symptoms, and you have to show 5 of these symptoms, and these 5 symptoms have to be present for continually for at least 2 weeks, more days than not. Okay? So it lays out very clear-cut criteria as to what is diagnosable. And so far in the history of the DSM, there have been 5 different versions. The very first version of the DSM started in 1952, so that's when the very first edition of the DSM came out. And it has since gone through several revisions and several different editions. And in fact, we are on the 5th edition now, so many of the disorders that we'll be discussing today are based on the DSM-5 criteria for these conditions. Okay. Important historical notes is right around the time of the DSM-3, which is developed in 1980 and published in 1980, or basically how people defined or put together these criteria in the DSM up until that point was based on expert opinion of a very few people. And in 1994, with the advent of the DSM-4, this is when the developers of the DSM started working together with what they called work groups, which are these network of experts or people who are viewed as experts in whatever diagnosis you're thinking of. So experts in depression would get together and they'd have a work group for depression, and experts in anxiety would get together and they'd have a work group for anxiety, and experts in autism would get together, so on and so forth, for all the different diagnostic categories. And during that time, this is exactly when they put together the criteria for these different disorders, as well as refine pre-existing criteria if it's a diagnostic category that had always existed. Okay, so that's fairly new. 1994 is when they started doing that. And with the DSM-5 is another big difference, or big change, is that they actually started incorporating some dimensional aspects into the diagnosis. So up until the DSM-4, it was very much a categorical approach, which says that depression is qualitatively different than no depression, and depression is qualitatively different from having an anxiety disorder. And there's no degrees of depression. Like, you can't have mild, moderate, severe depression. However, with the DSM-5, that changed. Now you can incorporate levels of severity into a diagnosis. Here's how the DSM-5, or the DSM generally defines abnormality. As you will note, the DSM does not diagnose based on the presence of a single symptom. So the DSM instead provides symptoms, a symptom checklist, as I was describing earlier, and gives very specific criteria for when the symptoms meet diagnostic thresholds. So the criteria that the DSM sets out defines a very specific number and configuration of symptoms, as well as a time period when the symptoms really need to be present. Okay, and it uses a combination of different criteria, some of which we discussed before, the deviance and the distress. And so it uses a combination of these to make an assessment as to whether the person's behavior is diagnosable. So it's not just the one criteria that is used, it's a combination of these different criteria. Okay. Something that's very interesting that's happened with the advent or the development or the publishing of the different DSMs over the generations. So these are, a graph showing you the number of the different diagnoses that you can make based on the DSM. DSM-1, this is DSM-2, DSM-3, DSM-4, or this is 3R actually. So this is number 3 revised. Oh, this is 4 revised, and then 5. As you see, started out with 128 at the DSM-1. So there were 128 different diagnostic categories in the DSM-1. In the DSM-5, we have 541. And I challenge you to think about what exactly is going on here. Why do you think that the number of diagnostic categories being introduced in the DSM is going up over time? Okay, really think about that. So no discussion of the DSM is complete without us destroying the DSM, basically, or at least pointing you to problems that are inherent with the use of the DSM. Before I say that, though, I want to tell you that the DSM is very commonly used and will continue to be used because the benefits of using a diagnostic system such as the DSM outweigh the cons of using something like the DSM. And the benefits include, and I think this is a pretty huge one, you're actually providing a common language that everyone trained in mental health can actually agree on. Okay, so I know if I read in a report, for example, and someone says the person meets criteria for a major depressive episode, I know exactly what that means. And I think most people who are trained in the DSM will know what that means. So it gives us a common ground as to discuss these conditions and to study these conditions and research, etc. So there is a very useful aspect of the DSM, and I think this is why it will continue to be used. However, we should also, as is the case with many of my lectures, we should discuss the problems with using the DSM. And the first problem is it's too inclusive, meaning it has diagnostic categories in there that may in fact be very normative. And I'll give you an example. There's caffeine is actually one of the substances for which you can be diagnosed as having a substance use disorder. Okay, and according to the criteria for caffeine use disorder, the majority of people in Western society would probably, or at least North American society, would probably be diagnosed with caffeine use disorder. Okay, so it's too inclusive. It may include people that don't necessarily meet diagnostic criteria, or at least not showing any kind of distress, into the fold of people showing abnormal behavior. So that's too inclusive. Oftentimes, the reliability of the different criteria are not very good. I'll give you an example of what that is. Lots of studies that show, especially this is more of a problem with the earlier versions of the DSM, like DSM 1, 2, and sometimes even 3. But 1 and 2 really had this problem of poor reliability. I'll give you an example. If one person shows up to my clinic, for example, and I use the DSM 2, and I give them a diagnosis of depression based on what they just told me, that patient can go next door and go to another mental health practitioner who also uses the DSM. The patient can describe the exact same symptoms, yet the second mental health practitioner may actually diagnose them with generalized anxiety disorder. Okay, so there's poor inter-rater reliability, especially in the earlier versions of the DSM. There's also the issue of heterogeneity of symptom profiles. And for this, I'm actually gonna do a little bit of a demonstration. And here's what I mean by heterogeneity of symptom profiles. Okay, and I'll demonstrate that to you right now. Here are the symptoms of depression, as is set by the Diagnostic and Statistical Manual. Okay. Now, the first two symptoms of depression are hallmark features of depression, meaning a person, if they are to be diagnosed with a major depressive episode, they have to be showing at least one of the first two, and then overall they must be showing 5 symptoms of the symptoms presented here. Let's say the symptoms of patient A, let's call them Adam, So let's say the symptoms of Adam are represented by the color red. Let's say Adam presents with sad or depressed mood, and Adam also presents with sleep difficulties, and then change in activity level, poor appetite, and decreased energy. That gives us 5. So if Adam is showing the appropriate or the time period which is set forward by the Diagnostic and Statistical Manual, which is showing these symptoms for 2 or more weeks, more days than not. So if Adam is showing these things, plus a bunch of other things, and showing or presenting with these particular symptoms that I've changed into red, they would get a diagnosis of major depressive disorder. Now imagine with me, there is a patient B, let's call them Bill. And let's give Bill the color green. And we'll say Bill doesn't present with sadness, but instead Bill presents with loss of interest and pleasure in usual activities. Sometimes we call that anhedonia. Okay, so Bill presents with loss of interest. They also present with decreased energy, negative self-worth or self-blame, difficulties concentrating, and having suicidal thoughts or recurrent thoughts of death or suicide. And we'll just highlight that using the green color. So really, the only symptom that overlaps between Adam and Bill is this symptom right here. However, both Adam and Bill would get the exact same diagnosis of clinical depression or major depressive episode if they showed up to my clinic according to the DSM. And that is exactly what we mean by heterogeneity of symptom profiles. People that share even the same diagnosis according to the DSM could have entirely different symptom profiles. In fact, out of the 9 symptoms, Adam and Bill are only sharing this one symptom out of the 9. Okay, so it almost looks like an entirely different disorder, if you will. Okay, so that's what is meant by heterogeneity of symptom profile. And then the final criticism, the final criticism against or opposition against the DSM on this particular slide is that some of the subtypes that are featured in the DSM have not, unfortunately, been heavily empirically supported. Sometimes the work groups that work together to put these diagnostic criteria together, as mentioned earlier, these are experts in a particular field related to that diagnostic criteria. So sometimes these experts put in things that are relatively theoretical, that don't have a lot of empirical backing, and therefore the DSM does feature some of these unfortunate problems. And some of, or at least the categorical nature of some of the categories that we discuss in the DSM have come into question. Okay? And I'll give you an example of what that might look like. And in fact, some research suggests, for example, that some features of schizophrenia are both categorically different than what is typically seen in the general population, but some features are actually exist on a relative continuum, and therefore they share that dimensional feature or the dimensional approach that we talked about. So it's a very complicated picture, and sometimes, given this complicated picture of these behaviors that we're trying to categorize, sometimes the DSM gets it wrong. Okay, so if it pegs these behaviors as a completely different category, sometimes that gets it wrong. So these are the problems with the DSM. Now let's look back through time and through history and discuss some of the major models that were put forward to explain psychopathology or explain abnormal behavior across time. And some of the very early models of abnormal behavior or trying to explain abnormal behavior back in the day were dominated by supernatural or demonological types of explanations. But even the time before Christ, there were still actually a number of medical or biological models that were floating out there. And today we have a lot more models. So in environmental, socially based models of psychopathology, psychologically, or models where psychological features are heavily emphasized. And then there are integrative approaches, which we will discuss at the very end of this lecture. To some extent, all of these models still exist today, and in religious and spiritual circles, for example, you'll find some supernatural and demonological explanations of psychopathology. Obviously, the medical and the biological model is alive and well, and of course, environmental, psychological, etc. The thing to remember about all the different models or all the different explanations of abnormal or psychopathological behavior is that the treatment that is suggested based on this model almost always follows the ideas of the model. Okay, so if you think depression, for example, or anxiety or schizophrenia are biological psychopathologies, then you're more likely than not to suggest some kind of a biological or a chemical intervention to help or treat that particular problem. Okay, so the treatment almost always follows whatever the model suggests is the issue here to solve, as you can probably imagine. So that's a very important thing to know. Here are some historical highlights of how abnormal behavior and psychopathology have been conceptualized over time. And in the Stone Age, there were lots of theories, as mentioned earlier, related to spiritual factors in affecting abnormal or psychopathological behavior. For that reason, a lot of people during the Stone Age practiced something called trephination. And trephination is literally making a hole in the skull to let out evil spirits. And I'll give you an image of what that of a skull that was found. The victim here, and I say victim because of course there's no proof at all that this method worked, but the victim here was the subject of trephination. So these holes right here would be drilled to let out evil spirits, which were believed to be changing that person's behavior, making them act in abnormal or pathological ways, if you will. There's later theories that suggest that trephination was done not just for that reason, but in fact also to reduce brain swelling, for example. Okay, in either case, that's what it would look like, and that's called trephination. As far back as 470 BC, and if you're familiar with the Hippocratic oath that all physicians have to say when they're becoming a physician, and that goes back to the philosopher Hippocrates. He was actually one of the very first people to suggest a medical or a biological basis for abnormal behavior. And Hippocrates really emphasized the role of what he called humors, or bodily fluids. And he said that there are four major bodily fluids that exist throughout the body, and those are the blood, black and yellow bile, and then phlegm. And these bodily fluids have to be in balance with each other in order for the person to have optimal mental and physical health. Okay? And he suggests, for example, that anything that is out of whack in the body, and for example, if there's too much blood, for example, they would show some kind of a corresponding psychological condition or psychological ailment. So too much blood, changeability. Too much black bile, you'll be melancholic or sad. Too much yellow bile, you'll be anxious. Too much phlegm, you'll be sluggish. Okay, so really, Hippocrates is credited to be almost the founder of the medical model, if you will, or the biological model of understanding psychopathology. One very important thing to also credit that particular movement, and Hippocrates in specific, is that there were a number of conditions very similar to what we call mania, for example, very similar to what we call depression now, that were specifically conceptualized during that era. Okay, so even these concepts that we recognize today as forming a particular syndrome, such as a manic episode or a depressive episode, etc., were recognized in even the days of Hippocrates, even the birth of Christ, before the birth of Christ. Around the Middle Ages, there was a resurgence of supernatural and demonological models of psychopathology. And also around that time, especially in Europe in the Middle Ages, something interesting started happening, which is the Salem witch trials. And these are trials for anyone suspected of practicing witchcraft. Okay, and that was all inspired by a particular text at the time called Malleus Maleficarum, which is literally translated as the witch hammer. The witch hammer laid out criteria for which to look for, or at least signs that somebody might be practicing witchcraft, and unfortunately many of these signs coincided with abnormal or bizarre behavior that would most likely be accounted for by some kind of a psychopathology or psychological condition. But at the time, it was seen as a sign of witchcraft, which was viewed as extremely antithetical to the Catholic Church at the time. So this is the beginnings of the Salem witch trials, in which people were brutally tried for their witchcraft, and also gave a rise or a resurgence again to the concept of exorcism as treatment for many of the conditions people were showing, or many of the symptoms of psychopathology that people were showing. And here's a famous painting of a woman being exorcised here, a woman who was believed to be possessed by the devil or a demon, and therefore she was showing a lot of bizarre signs at the time, or symptoms of what we'd call a psychological condition now. So this type of treatment to people who are showing signs of abnormal behavior or bizarre or socially unsanctioned behavior culminated in the development of asylums, if you will. And these asylums were extremely brutal places. And in fact, many of these asylums that were designed to house people who society had forgotten about, basically, or society couldn't understand their behavior, were so severe that oftentimes they included things like chains and shackles. They electrocuted people. They put them in isolation. They exposed them to the natural elements. It was an extremely horrific way of treating people showing signs of psychopathology. And if you have the time, I do challenge you to stop the video right now and watch the embedded YouTube clip, which is right here, which you'll find embedded in the lecture slides as opposed to the video itself. And this particular YouTube clip goes through the history of a very, very famous mental hospital or an asylum that was developed in the Middle Ages there. And it was famous and infamous at the same time for its very poor treatment of people with a psychological condition. And it's actually right in the heart of London. And, the remnants of it still exist on. Anyways, the very poor treatment of people showing psychological distress was not really making people any better. And one person who caught on to this trend very quickly is Philippe Pinel, who was a French physician who was assigned the duty to direct a mental asylum at the time in France. And what he saw was that the treatment that they were giving to these people who were showing signs of psychopathology was not at all appropriate. And he suspected that this very brutal treatment, shackling them up, electrocuting them, not giving them enough nutrition, making them sleep on straw beds, etc., all of these things were actually contributing or exacerbating their condition. And what he suggested instead was a reform to this way that we treat people with mental health conditions. And that rushed in. So Benjamin Rush, for example, was an American who took on the same ideals of Pinel at the time, and he suggested a reform as well. And this reform took the form of what is now called moral treatment for people with mental health conditions. And moral treatment is basically treating people who are in these mental health facilities with dignity, with respect, providing them enough nutrition, providing them enough nurturance. And this really rushed in a new way to deal with and to care for people who are showing psychological distress. Okay, so it was a very different way of thinking about this particular issue. And here are other very important highlights that we often talk about in the history of abnormal psychology. So one of the major things that I will discuss is the Emil Kreplin's compendium, which he put together of all conditions that are both physical and psychological. So he was one of the very first people to actually classify symptoms into syndromes and talk about them as if they're existing entities. They're an existing construct. Very, very similar to the classification that we have currently in the DSM. So Emil Kreplin's work really inspired works like the DSM. Okay? And of course, we talked about the emergence of psychoanalytic theories of personality, behavioral models that followed shortly after, and of course the third force or humanistic models that came out, and of course the biological models that existed since the time of Hippocrates that of course continue to shape the field of abnormal psychology extremely heavily. And of course there's the cognitive revolution that happened in the 60s and 70s, and that continues to go into its third wave currently. So we're in the third wave of the cognitive revolution. We're about to turn a new leaf, actually, and go into the fourth wave of cognitive revolution. Here are the models of psychopathology that still exist today. The medical or the biological model is still, of course, as I said earlier, alive and well. And the medical model of psychopathology really focuses on physiological features that would underlie the development of a particular psychological condition. Okay? So it really tries to find the biological causes of abnormal behavior, if you will. Okay? So it's obviously very, very much influenced by medicine, but the medical model assumes that psychopathology or abnormal behavior generally can actually be diagnosed, and it can be cured as any other physiological condition can be. Okay, so that's the approach of the biological or the medical model. Of course, the psychodynamic model is still alive and well today. Okay, which of course has roots in Freud's psychoanalytic psychotherapy, and the basic assumption here in the psychodynamic model of psychopathology is that psychological disorders develop based on unresolved conflicts that lay beneath the person's awareness. Okay? And in fact, you need someone like a mental health practitioner who is practiced in psychoanalysis, who can actually help you wade through the unconscious conflicts and bring these to the forefront in order to help you get over the symptoms that you're experiencing. Okay, so the basics of the psychodynamic model go back to the basics of the psychoanalytic approach, which say that whatever symptoms you're experiencing, it's because of unresolved conflicts that are happening beneath the threshold of awareness. And of course, there's the humanistic model, the third force, as they used to be called. And this, again, if you remember our discussions on the humanistic theory of personality, from a humanistic perspective, people are inherently good, and people are striving towards self-improvement and eventually self-actualization. Okay? So if you create an environment for them to thrive and you just get out of the way, they will achieve that self-improvement and self-actualization, if you will. And therefore, the humanistic model says that maladjustment or psychological disorders or abnormal behavior happens when the environment is not enough for the person, that it's unable to meet their needs, if you will. So in order for us to reverse that trend, we have to create environments that meet people's basic needs for dignity and for uniqueness and ability to make decisions. Cognitive models and behavioral models are, of course, some of the most dominant right now. And the behavioral model focuses solely on the patterns of behaviors that are reinforced and patterns of behaviors that have been punished over time. So really, really focuses in on behavioral contingencies, meaning, So a model of depression, for example, would say that somebody is displaying symptoms of depression because somehow they're being rewarded for these symptoms. And of course, there's the cognitive model. And the cognitive model really emphasizes the role of interpretations and thoughts and cognitions in determining whether somebody will develop a psychological condition. Okay? So the assumption here is that psychological disorders, as well as abnormal behavior, arises because people have faulty or maladaptive interpretations of the world around them. And that is precisely the target of intervention in cognitive theories or cognitive therapies of psychopathology. The target of intervention here is the cognition or the interpretation. So the patient and the therapist work together to reinterpret important events and reinterpret the environment which surrounds the patient. There's the sociocultural and evolutionary model. Core elements in the sociocultural model are things like family, community, and society. So it doesn't really take an individualistic approach. It zooms out and mostly focuses on bigger systems in which the individual interacts: family, community, society. And the basic assumption here is that psychological conditions or disorders arise because there is a problem in the bigger system, that is family, community, and society, and not so much a problem with the individual themselves. So that's the sociocultural approach. The evolutionary approach, evolutionary models of psychopathology say, for example, that what we call a maladjustment was actually at one point in our evolutionary history beneficial to people in some way. Okay, and or the symptoms of psychopathology are a byproduct of a function that used to be evolutionarily adaptive or continues to be evolutionarily adaptive. Okay, so I'll give you an example. One major example of an evolutionary model of depression talks specifically about the role of rumination, and we talked about rumination in our stress and coping lectures. Rumination is basically a psychological style where you're regurgitating certain thoughts about why you have symptoms. You're going over events in your mind once, twice, a million times. And we know from a lot of research that rumination highly positively correlates with depressive symptoms, and it predicts depression over a long period of time, actually. An evolutionary model of rumination says that rumination is the brain's way of trying to solve the problem of depression. So it was evolutionarily adaptive at one point or another. However, the mechanism is broken somehow in people who are more vulnerable to depression, and therefore the thing that used to be functional, which is this, thinking about the causes of your disorder, is now completely out of whack and causing some kind of a dysfunction. So all of these models exist or are emphasized in some way today. However, most of our psychological models of psychopathology today takes into account all of such factors. And I hope over the span of our course together, you saw that there are no theories that are complete on their own. There is no theory which captures the human condition perfectly. There is no one level of analysis that will do justice to the human condition. And therefore, you have to include all of these factors to try and understand the fuller picture of what is going on in human psychopathology. And that is exactly what the biopsychosocial model does. It emphasizes the biological and the social and the psychological aspects of abnormal behavior, and says that all of these factors of biological, psychological, and social factors are interacting to produce or to give rise to these conditions. So obviously some of these biopsychosocial models will emphasize biology more than psychological factors, or they'll emphasize psychological factors over social or biological factors. But for the most part, most contemporary theories of abnormal behavior will emphasize all three to some extent. Okay? And we also are inspired nowadays by what we call the life stress model, or the diathesis stress model, which says that people develop conditions when they have a pre-existing vulnerability for that condition, and a certain life circumstance, for example, a particularly stressful time during adolescence, interacts with that vulnerability to produce the symptoms that we see as psychopathology. For example, it's like a lock and a key. Okay, so there is a lock here that lays dormant, which is the biological vulnerability for a particular disorder, for example. So you may have genes for a particular disorder that never become expressed because you weren't in environments that would allow for that gene to express. Okay? And that is exactly what we mean by diathesis stress, is that there's some kind of a vulnerability that is pre-existing, that is for the most part dormant until it meets a particular environmental factor or condition which gives rise or makes these genes express into what we see as abnormal behavior. So here's what the biological or the biopsychosocial model would look like. Right? So there's obviously emphasis or the impact of biological and social and psychological factors are all emphasized in these models, and all of which interact in a very dynamic way to give rise to psychopathology. And here is a depiction of the vulnerability or the diathesis stress model. There's some kind of a vulnerability that exists and interacts with a particular stressor, and like a lock and a key, it starts a mechanism that kind of blossoms into what we see today as psychological disorders. Until next time.